Good evening. My name is Professor Leanne Young. I'm teaching the maternal and newborn class for Fortis College. And this week I will be lecturing on our week 4 content, which is going to be covering postpartum nursing care. So last week we talked about the labor and delivery process, the 5 things that affect labor, the 5 Ps. We also talked about fetal heart rate tracing, what different decelerations mean, what we need to do as nurses to intervene for those that we need interventions or that require interventions. So we talked about the labor process. We talked about how we can support our moms during labor, both from a non-pharmacological and from a pharmacological standpoint. Now we're going to be moving on to the postpartum side of things, which is just as important, if not more so, as far as our assessment goes and the things that we need to be looking out for during this stage of delivery and recovery. So let's start first with what is the body doing? What are the physiologic changes that mom is undergoing during the postpartum period? Okay, so we're going to discuss briefly our reproductive system and associated structures and how they are impacted in the postpartum period. So the biggest thing that we're talking about here is our uterus. Obviously, we just had a baby. The uterus is a giant muscle. It's a giant, it becomes enlarged during pregnancy, obviously, to accommodate the growth and the size of the fetus. Um, but what we are looking for as in our part of our nursing assessment is what we call involution. And this is the return of the uterus to a non-pregnant state after birth. Okay, so just to give you an idea, right? Your uterus normally is usually typically like not bigger than the size of an apple. Okay. During pregnancy, it grows up to be like the size of like balloon size. It's pretty large. Involution means that our uterus is going to gradually just return to that non-pregnant state, so that apple shape or apple size uterus after delivery. So at the end of the third stage of labor, the uterus should be midline, approximately 2 centimeters below the level of the umbilicus, so the belly button. And then within 12 hours, the fundus can rise to approximately 1 centimeter above the umbilicus. So it goes up a little bit. And then by 24 hours after birth, the uterus is about the same size as it was at 20 weeks of gestation. So our uterus is a pretty amazing muscle. It is going back to its normal size and it's retaining its shape pretty quickly. Okay. It begins immediately after the placenta is expelled, after we've delivered our placenta. So like I said, it descends 1 to 2 centimeters every 24 hours, and it returns to a non-pregnant location by about 6 weeks postpartum. Okay. So our job in the immediate postpartum period is to assess where that fundus is. Where is that uterus in relation to the umbilicus? Is it 2 centimeters below? Is it 1 centimeter above? Is it at the level of the umbilicus? And then where is it going as mom is recovering and as she gets further away from after delivering her baby? Okay. Um, One thing that we're doing during this period and how we assess for involution is we are performing fundal massage. This is something that we're going to talk about more extensively as well during class time. But fundal massage is the assessment that we use in the immediate postpartum period to see if mom's uterus is contracting down and it's returning back to that non-pregnant state. It's remaining firm. Okay, so your uterus, a good assessment for a uterus would be your uterus is firm, it is midline, it should not be off to one side or the other. And you should have minimal amounts of bleeding whenever you're pushing down on that uterus. If you're pushing down on that uterus and you're getting clots and clots and clots and clots, there's typically something else going on that we need to be aware of or that we need to be worried about. Okay. Um, we'll talk more about that here in a couple slides. Another term I want you guys to be familiar with is autolysis. So this is the increase in estrogen and progesterone levels, and it's responsible for the massive growth of the uterus during pregnancy. And then once these levels drop, autolysis is going to occur. So that is the self-destruction of hypertrophied tissue. So those estrogen and progesterone levels, they are so increased during pregnancy because they are sustaining the uterus, they're sustaining the placenta, they're sustaining the pregnancy itself. Once those levels drop, you're going to have that dramatic destruction of tissue. And that is also what's going to help get our uterus back to its pre-pregnancy size. Okay. Subinvolution. This is the failure of the uterus to return to a non-pregnant state due to ineffective contractions. So, like I was talking about, when we're performing a fundal exam or we're doing a fundal massage or uterine examination postpartum, we want that uterus to be nice and firm, okay? That is showing that our uterus muscle is contracting down. And with those contractions, it's shrinking, it's getting smaller, it's returning to its natural state. Um, if this is not happening, it's usually because we have a retained placenta, excuse me, a retained placenta or retained products, or like trailing membranes or something like that. There's something that's going on inside or that's causing this uterus not to contract and not to return to its pre-pregnant state. This is when we see a lot of bleeding. We might see mom hemorrhage. We might see her go into like hypovolemic shock. Um, Different things that can occur whenever our uterus is not returning back to its natural state. Okay, so subinvolution is that failure of the uterus to return to a non-pregnant state due to ineffective contraction. So it's just not clamping down. That uterus is not contracting and shrinking, and it's staying aggravated after delivery. So we talked a lot about, or I mentioned a lot about contractions. Okay. Obviously, you need to have contractions on the uterus to have a labor, to have a delivery, to cause that effacement and cervical dilation and change. But contractions also play a role in postpartum just as much as they do intrapartum, and during delivery. Okay. So homeostasis in postpartum period is achieved through uterine contractions rather than clot formation. Okay. Your body, or at least the uterus in this instance, is not forming clots in order to heal. Okay, that's usually our defense mechanism, our first defense mechanism in the body. This is different with a uterine. I guess you consider it an injury, but it's just after the delivery. Contractions are what's going to be causing the body to return back to its hemodynamic state. Okay, so we need to have proper uterine contractions to reduce the amount of bleeding that mom is having, to get that uterus back to its regular size, to shrink it, and to make sure that mom remains stable. Okay. Release of oxytocin from the pituitary gland is going to strengthen contractions. Okay, so during labor, we are producing oxytocin. Sometimes we may need to give a little bit more of the oxytocin depending on what the contraction pattern is and how mom is progressing throughout her labor. But after delivery, a huge release of oxytocin occurs as well, which is going to increase contractions and cause that uterus to clamp down and return to its natural state. Okay. We are also going to be giving IV, or IM, sometimes it's given intramuscularly, oxytocin to assist in uterine contractions postpartum. Typically, what's going to happen is a placenta is delivered, and your provider is going to say, open up your pit, and you're going to bolus in your IV Pitocin, or you're going to give it at a rate that they tell you to give it, whether that's for a 2-hour period or however it is the provider orders it. Or placenta is delivered, okay, let's administer an IM dose of oxytocin. This is just going to increase the amount or add to the amount that our body is already producing in order to effectively have our uterus clamp down and prevent mom from bleeding too much, okay? A firm uterus means less bleeding. A soft, squishy, boggy, if you see the word boggy, that means not contracted. A boggy, relaxed uterus means clots and bleeding, okay? Breastfeeding is going to increase oxytocin release. So that's why sometimes moms will complain during breastfeeding that they're having a lot of cramping or a lot of discomfort. It's because breastfeeding is going to naturally increase our oxytocin production. So if you have a mom that's bleeding and she's hemorrhaging, is that the time to breastfeed your baby or latch baby on? Not necessarily, because we're probably going to be doing a lot more interventions and trying to stabilize mom, right? So breastfeeding would not be the priority at the time. But it is important to know that breastfeeding can increase your oxytocin and will cause mom's uterus to cramp. What kind of factors do you think may increase a woman's after pains. And when I say after pains, I mean like the amount of contraction that she experiences after the placenta is delivered, as that uterus is trying to shrink back and return back to its normal size. I'll give them to you. So a mom's age will affect this, okay? The older a woman is, typically the worse her after pains are because her uterus is working harder to return back to that pre-pregnancy state. Gravity. So how many times has this mom been pregnant? Okay. If this is a first-time mom, odds are that her cramps are going to feel very similar to just like period cramping, a little bit of discomfort. She might need some Motrin to help with them, but sometimes not even that. Pretty mild. If this is a woman's like 10th pregnancy, okay, that uterus is tired. That muscle has been worked pretty hard. So their muscle has to work harder, ultimately causing more painful, stronger, more frequent contractions in order to return that uterus back to a regular size. Okay. So usually the more pregnancies you have, the worse the after pains can be. Any case where a mom's uterus grew to an extra enlarged state. So, like whether that's a macrosomic infant, like a really big baby, which we talked about, I mentioned that briefly in like diabetic moms. If a mom has gestational diabetes, that baby is at a higher risk for being macrosomic or big. With a big pregnancy or a big baby, that uterus is stretched even larger than what it would have been. So returning it to that size is going to take a lot stronger, harder, more painful contractions in the postpartum period. So you can see moms that have worse after pains with a big baby. Same thing with like twins or multiples. We have an enlarged uterus, so therefore it's going to be working harder to return back to its normal size. And then if mom has excess amount of amniotic fluid, which is called polyhydramnios, we covered that a little bit. Polyhydramnios causes that uterus to stretch even bigger to make more room for the amniotic fluid that is growing. Um, Therefore, that uterus is going to have to contract harder to get back to its normal size. Okay. And then, like we mentioned, breastfeeding. Okay. Breastfeeding is going to cause that uterus to cramp. So those are some things that may affect, increase a woman's after pain. And when we're talking about the placental site, what is happening there, right? We had a placenta that was adhered to that endometrial lining to sustain a pregnancy for about 9 months. It detaches, hopefully on its own at a normal time without any intervention from the provider. What is happening to that endometrial wall? Like what do we expect? So endometrial regeneration begins within 3 days after birth and is completed by the third week. So that spot where that wound or that placenta was adhered, it's going to regenerate 3 days after, begin regenerating 3 days after birth and complete by the third week. Um, Regeneration at the placental site is completed by the sixth week. So if you have had a child or if you know someone who's had a baby or you've worked in L&D before, you know that we typically tell moms not to have sex until about 6 weeks after delivery because they still are healing. And that is even with a typical straightforward vaginal delivery. It is because they have a wound inside where that placenta was adhered to the endometrial wall. So that's why we say no sex until 6 weeks because we are waiting for that placental site to regenerate that endometrial lining um, before engaging in sexual activity. So that won't be done by this until the sixth week. Okay, so that's why we tell moms that information and tell them to wait. Part of our postpartum assessment, and a really big part of it, is lochia. Okay, so this is the fancy word that only labor and delivery nurses use, and it's only relevant in the labor and delivery world. Lochia is post-birth uterine discharge, uterine bleeding following delivery. Okay, it occurs for 4 to 6 weeks after the birth or the delivery of the infant, and there are different stages of lochia depending on how far out postpartum. I would star, highlight, circle this because you guys are definitely going to have to be able to identify what the stage of lochia is and what the characteristics of the bleeding will be. Okay, we're going to talk about that more in 2 slides, but I have 2 pictures here included for you that show some postpartum bleeding stages as well as break it down, rubra, serosa, and alba into those three categories that you will need to know for your exam. Okay, what else is happening in our body? So with the cervix, okay, the cervix just expanded to 10 times its normal size. Okay. It's going to be soft immediately after birth. We might have it, it might be bruised. There might be some edema, and some small lacerations can occur. Okay. That cervix just grew to an astronomical size, and it's going to start becoming shorter again. It'll become firm and it'll regain its form within 2 to 3 days postpartum. That is like a really, really fast recovery time. So your cervix goes from being closed all the way to open enough, big enough to let a whole baby through. And then in 2 to 3 days, it's going to be almost back to its normal form. Okay. It's going to return to 1 centimeter dilation post birth, 1 week post birth. Some other information for you, which is just extra tidbits. If a mom has had multiple deliveries, her cervix may not fully ever return back to just 1 centimeter. Okay, there are some moms who will sit at 3 centimeters forever just because they've had like multiple kids and have delivered multiple babies. But for the purpose of this class, you just need to know that it will return to 1 centimeter dilation 1 week post birth. Okay, the ovaries and ovulation. This is a really important one that we want to talk about. So, this is going to be different in lactating versus non-lactating women. So whether or not a mom is breastfeeding is going to affect whether or not she begins ovulating, and when she starts having a period. Okay. Typically, 27 days postpartum in non-lactating, a woman will begin ovulating. So 27 days after she delivers, she'll start ovulating again if she's not breastfeeding. Typically, for breastfeeding women, it takes 6 months for their ovulation cycle to return. This excuse me. This is different for every woman, okay? So if a woman is saying that she's not planning on using contraception because she's breastfeeding, we need to still educate her that that is not a foolproof method of contraception. She still needs to probably go on birth control or use condoms or some other type of contraception if she's trying to avoid a pregnancy, because oftentimes that's not reliable because it can differ for each woman, okay? Our hormone that is responsible for ovulation suppression is the serum prolactin levels, because this is what is present in a lactating mom, and that is going to suppress ovulation. Okay. But like I said, we need to educate our patients that breastfeeding is not 100% foolproof for preventing pregnancy in the postpartum period. Okay. The vagina and the perineum. So, because of this massive fluctuation or decrease in estrogen production, so like I said, our estrogen and progesterone levels are high during pregnancy to sustain the pregnancy. Then they drop rapidly after the delivery of the baby and the delivery of the placenta, really. Because of this decrease in estrogen, the vagina is going to be extremely dry. Okay. Moms overall will have just like feel dry. Um, is just part of that estrogen dropping. So they're going to have discomfort with sex. Okay. We need to educate our patients about this because we don't want that it to be painful. The first time that they have sex after delivery, we need to educate them that they may need to use lubricant or other sources of lube so that it's not as uncomfortable for them. Okay. We need to look at their episiotomy or vaginal laceration. So if a mom tore during delivery, depending on whether it's a first, a second, a third, a fourth, um, whatever it may be, we need to look at her perineum at her bottom and assess for any signs or symptoms of infection. Is it edematous? Is it red? Is it open and bleeding again? Has she developed anything abnormal like a hematoma? Like we need to be looking at her perineum, and assessing that. Okay. Especially for an episiotomy, which is when it was a cut made by a provider in order to make room for the baby. We need to be looking and making sure that that is healing properly. We also need to tell our patients how to check for the signs and symptoms of infection themselves. Okay. You guys should know the signs and symptoms of infection: fever, flu like symptoms, cold, body aches, chills, anything like that. Any weird discharge coming from their vagina, any abnormal smell, if it's burning or it's itchy, anything like that, they need to call their primary care so they can get antibiotics and be assessed. Okay. Our pelvic muscle support. This is can be injured during delivery. We need to teach our patients Kegel exercises and when to return to normal routine exercise. So during birth, they're using all of their pelvic floor muscles and assistance to help push that baby out. So your pelvic floor after delivery is not going to be the same as it was before delivery, especially if it was a first time mom. So we need to educate them that, yeah, if you're planning to go back and work out, that is fine, but we need to make sure that you're also establishing some pelvic floor exercise to ensure that you're strengthening those muscles as well, which are just as important. Okay. It may take a mom up to 6 months to regain back her pelvic floor muscle tone, just so that you're aware, so you can tell your patients that sometimes it takes a little bit longer to regain our muscle tone after delivery. Our breasts. So during pregnancy, your breasts change like crazy because of that estrogen and progesterone increase in your body. They get bigger, they swell, they're more tender. They may have some colostrum production in the third trimester or late second trimester. All sorts of things are happening to our breasts. Our breasts are changing even more after delivery to make room for milk and to produce the correct amount that we need to feed our babies. So, with breastfeeding, colostrum. I want you guys to know what this is for sure. Colostrum is that early milk, and I have pictures of it here, down here, what the milk starts to look like and how it transitions. Early milk is what we call colostrum, and it is that gold in color. Okay. It's super antibiotic rich. It gets all the stuff, um, pathogens and stuff from mom to help build a baby's immune system. Colostrum is jam packed with all the things that babies need in those first couple weeks of life. Um, Mom's breast may feel warm and somewhat tender during this stage of like the early breastfeeding with the colostrum and early milk production. And then later they may be like tingly whenever they start to have letdown or they are producing like their actual milk. Breasts can become engorged, which just means like really large, hard, firm, painful. This is only typically lasts about 24 to 48 hours, and it usually occurs in moms who choose not to breastfeed because their milk glands and their ducts they still have an increased amount of serum prolactin levels for that short period of time. So their breast tissue is trying to make and produce milk, and if that is not being sucked out and excreted by an infant swallowing and breastfeeding, it has nowhere to go. So you're going to see that breast engorgement. Just educate your patients on compresses, on avoiding stimulation to the breast tissue. Don't be pumping or expelling it because your body will just keep producing more, and that it will stop 24 to 48 hours later. Non-breastfeeding moms, their breast tissue also will sometimes feel more nodular. So, like, it can have a little bit more like dense spots, dense areas. That's normal. Prolactin levels, like I've mentioned, are going to drop rapidly. Colostrum will still be present for a few days after birth. That's something that moms will produce oftentimes during pregnancy. So, that's not going to just stop after the delivery of the baby. And like I said, they may experience engorgement, that large, swollen, firm, tender, and warm to the touch breast tissue. All right. So moving on now to the types of lochiel that we kind of hit on whenever, like 2 slides ago. Um, Page 455 has a table that goes through all of the characteristics of the different stages. We're going to hit on the highlights and on the big points, okay? So the first type is rubra, okay? That's the Latin word for red. It looks like, what does it look like? It's bright red and it lasts usually only 3 days. It's that immediate postpartum bleeding, okay? It is a heavy flow. So typically it's one pad every 1 to 2 hours for the first 2 to 3 days. So this is like the first day of your period. Okay, really heavy. It smells like a period. It's that slightly metallic smell. Some small clots are okay. We tell moms that we just don't want them to be any larger than a golf ball. So like some small grape-sized clots are fine. It's made of blood, mucus, and tissue. Um, It is coming from placental side. So you can sometimes see that like blood, mucus, or tissue. What is abnormal? And I want you guys definitely to know your abnormalities when it comes to the types of lochia. So if mom has a bad odor, it would be a sign of infection. If she's soaking one pad in less than an hour or less than 15 minutes, she's hemorrhaging, and that's an emergency. That's too fast. Okay. And if there's clots that are larger than ping pong balls or golf balls, like I said. So we just don't want those clots to be large. We don't want her to be bleeding more than one pad an hour. Um, if she is, those are things she needs to be assessed for. Okay. So, like I said, this rubra typically lasts 1 to 3 days and then it starts to change. Our next bleeding in this stage of bleeding would be lochia serosa. So this is that pinkish brownish blood, and it lasts about 7 to 14 days postpartum, days 4 to 10. Okay. This is a moderate flow. It's usually one pad every 4 to 5 hours, and it's going to start slowly decreasing. So it goes down and down the further out you are from being postpartum. It's odorless or sometimes has a slightly sweet odor to it. There should be like few to no clots within this bleeding. It's a mix of fluid, old blood, and mucus. Abnormal. So if mom all of a sudden says that her bleeding has picked up again, that's abnormal. If she has that bright red rubra return to her bleeding, it's like looks like she just gave birth all over again. That's abnormal. If she's having clots, we also want her to be seen. And then again, that foul odor would be a sign of infection. Okay, so we've had our rubra, we've talked about our serosa. The last one that we're going to talk about is our lochia alba, which is Latin for white. Okay, this is that whitish yellow discharge, and it lasts for like 12 plus days. And these are usually occurring around postpartum day 11 to about 6 weeks after delivery. Okay, this is a light flow. It typically only requires moms to wear a pad or a panty liner, sometimes not even that, depending on how much they're having. There's no odor, no clots. It's mostly mucus and white blood cells. There's very little to no blood in it, hence why it's not colored. Okay. Abnormals would be if it changes color, it goes back to looking like serosa or rubra. If there's an increase in amount of flow, or if there's any clots. Okay. Typically, clots in any type of stage of the bleeding is abnormal, and we'd want to have the mom get checked out. All right. So whenever we talk about pathophys, obviously we're going to be talking about what things happen to like our major vital signs, our major blood systems. So our cardiovascular system undergoes a lot of serious changes in the postpartum period. Okay. So blood volume. Um, Blood volume depends on the amount of blood lost and the amount of extravascular water intake. Okay. So, when we're talking about this, we're referring to pregnancy-induced hypovolemia. So this is an increase in blood volume of 40% to 50% above the non-pregnancy levels, which is what we talked about in during the first week or second week PowerPoint when we were talking about the changes that mom undergoes during pregnancy. So she's going to experience an insane increase in blood volume, 40 to 50% above those non-pregnancy levels. This excessive This excessive blood volume that has been built up over pregnancy allows for women to tolerate blood loss after the delivery of an infant. Okay. So mom's body is already preparing her for delivery way at the beginning whenever her blood volume and her blood components are increasing because we're trying to compensate ahead of time for the amount of blood that we're losing during pregnancy or during delivery, during birth. Okay. So I want you guys to know this. The average blood loss during a vaginal birth is typically no more than 500 mLs. Okay. And then the average blood loss for C-sections is no more than 1,000. Okay. You're going to lose more during a C-section because that's an open major surgery. Okay. So you're going to lose more blood. But your blood volume postpartum is greatly going to depend on the amount of blood that mom has lost, along with the amount of extracellular, extravascular water intake. Okay, so if she's gotten, how much fluid has she gotten during delivery or during labor? Our cardiac output. Immediate blood loss is going to reduce our plasma volume without reducing cardiac output, okay? Because we've built up so much excess, remember, in pregnancy. So we really should not be reducing cardiac output because we have that excess amount of blood volume anyways. Cardiac, cardiac output is going to increase immediately after birth by 60 to 80%, and it's going to return to pre-labor level within 1 hour. It decreases to pre-pregnant level by 6 to 8 weeks postpartum. So it still takes a while for your body to hemodynamically stabilize after delivery. So 6 to 8 weeks until we're seeing like our normal cardiovascular system levels return. But it's returning to that pre-labor level within 1 hour. Okay. So it increases immediately up after birth by 60 to 80%. What is going to occur to our vitals? Page 457, table 18.2, goes into excessive in a lot of detail about this. Um, Vital signs and what I want you guys to know and think about, just um, thinking about it from a nursing standpoint logically. There should not have be any changes to your vital signs under a normal circumstance. Okay, so if mom has delivered, her bleeding is under control, um, the placenta delivered appropriately, she's been repaired, her fundus is firm, she's not having a lot of bleeding. Why would her vitals change, right? Her vitals are going to stay the same. Her vitals should be normal, okay? If we see an increase in temperature, um, or an increase in her heart rate, or an increase in her blood pressure, then we're going to start wondering, like, what else could be going on? If you have an increase in temp, what are we immediately going to think? Fever, infection. Maybe mom had some type of choreo infection of the amniotic fluid. Increase in her heart rate or increase in her blood pressure or increase in her heart rate could be a sign that, we're losing a lot of blood. We're trying to compensate for the amount of blood lost by that heart rate going up. If she has an increase in that blood pressure, maybe she's developing preeclampsia, which you can develop after delivery. That might require magnesium or other medical intervention. If blood pressure is decreasing, are we losing too much blood? Right? So these are all things that we need to think about from a logical standpoint as a bedside nurse. What do our vitals tell us about our patient? If your patient had a standard delivery, most of the time her vitals aren't going to change for a vaginal delivery, right? After a surgery, if she's had anesthesia, we're expecting her blood pressure to be a little bit lower. We're expecting her heart rate maybe to be a little bit elevated because she just had a major surgery, right? But in a typical standard delivery, vaginal delivery, we really shouldn't see too many drastic changes in her vital signs. Okay. If mom had varicose veins or any varicosities during delivery, during pregnancy or before birth, those are going to decrease drastically after birth because we're getting rid of a lot of our blood volume, right? Um, and just overall, those veins are going to reduce because there's not as much pressure throughout the body. Okay. Our hemoglobin and hematocrit is going to decrease over 24 hours. Our white blood cell count will rise naturally. Our clotting factors are going to be increased. So mom is still hypercoagulable. We still need to educate our patients on DVTs. So please, please, please know the signs and symptoms of deep vein thrombosis um, and other clot formation or clot um, patterns. Okay. What other kind of changes are we going to see? For our respiratory system, our intra-abdominal pressure is going to be definitely decreased, right? Because that baby was delivered. So that baby's gone. That uterus isn't necessarily pushing up on the base of the lungs on the diaphragm. So mom's going to have an easier time catching her breath because she doesn't have that pressure pushing on her diaphragm, restricting her lung expansion. Um, Decline in our progesterone levels is going to result, excuse me, and partial pressure of CO2 levels to rise. Okay. Um, the biggest one on this slide, I think, for you guys to know would be our hormone levels. Okay. So, what are the hormones or the placenta? What is affecting that? Once the placenta is delivered, there's a drastic decrease in estrogen and progesterone, which we've talked about. Decreased estrogen is typically associated with diuresis of excess extracellular fluid that has accumulated during pregnancy. So, if you hear moms postpartum say that they sweat all the time, um, that is because that decrease in estrogen production is going to help with diuresing or getting rid of that extra fluid that has been built up during our entire pregnancy. Obviously, our HCG levels are going to decrease. That's the pregnancy hormone, right? And a decrease in hormone production will ultimately cause a decrease in blood sugar. So, for our diabetic patients who have been managing and adjusting their insulin levels throughout their entire pregnancy, we need to educate them and tell them, okay, because of this, your blood sugar levels might decrease. So, we need to keep a closer eye on what your blood sugar looks like right now. As far as our pituitary, so after delivery, the fall of progesterone is going to cause an increase in prolactin, which is the hormone that is going to produce our milk, right? So with estrogen, you're looking at a diuresis of that extracellular fluid. With progesterone, we're looking at an increase in our prolactin production, which is the hormone that produces milk. The posterior pituitary, also remember, we talked about this a couple slides ago, is what produces oxytocin in response to the infant suckling or nipple stimulation with milk expression. Okay. So, baby is sucking or breastfeeding. That's going to trigger the posterior pituitary to produce oxytocin. And that oxytocin is going to trigger the letdown reflex, which is going to release the milk to the nipple from the alveoli to the breast where it's produced. Okay. So, without oxytocin production, that baby is not going to be receiving any milk because we're not going to have that letdown reflex and the release of the milk into the breast tissue or to the nipple from the alveoli. Okay. Our renal system, and there's going to be an increased renal function, which may cause a patient to be at a higher risk for UTIs. Okay. She's still going to be peeing a lot because we're diuresing and trying to get rid of that fluid. She's also at a risk for dehydration because of the fluid they lost due to a decrease in estrogen levels, right? So, like I said, mom might encounter profuse diaphoresis where she's sweating like nonstop all the time. If this is her, we need to tell her she needs to increase her fluid intake because her body is excreting so much of it through sweat, urine, whatever it may be, right? So she needs to still be drinking lots and lots of water. GI system, moms may not have a bowel movement for about 2 to 3 days postpartum. This is because there's a slowed peristalsis related to a decreased muscle tone in the intestines during labor. There also might be some injury to the pelvic floor muscles. Mom might have a hemorrhoid or two. And if she's postpartum from a C-section or a pretty intense vaginal delivery or vaginal repair, and if she's receiving opioids, that's going to decrease our peristalsis in the GI system and result in constipation. Okay. For our musculoskeletal system, it takes about 6 weeks for the abdominal wall to return to an almost pre-pregnancy state. So I have that picture there of a normal abdomen, right? And then what we call diastasis recti, which is what happens um, when the muscles kind of spread apart in order to make room for the growing uterus and for the growing fetus. Okay. Um, Sometimes it can be sooner or later for these muscles to return back to their normal state depending on the status of the abdominal muscles before delivery. So if a mom was super active and used her abdominal muscles all the time, or if she worked out during her pregnancy and was still using those muscles, she might have a quicker recovery following delivery than those who may not be using those muscles regularly. Okay. Diastasis recti does not necessarily require surgery. Okay, that's not something we have to operate on, but it might be uncomfortable to the mom. It also might affect her body image, her self-body image. So we just need to talk to her about it and tell her that like things that we can do to try and correct this or educational resources for her. Okay. From a neurological standpoint, headaches are common, but they must be assessed carefully. We're also going to talk a lot about postpartum psychosis, postpartum depression, how all these hormone fluctuations and what's happening in the postpartum period can affect moms and their overall moods, and what we need to be telling our patients to look out for. Okay. So, moving on here to the nursing care of the family during the postpartum period. Um, the biggest thing that we need to be talking about is What is the nursing role? Okay. We're providing physical assessments. We're doing those fundal exams. We're ensuring mom's vitals remain stable. We're watching her very closely in the postpartum period. We're most likely doing her vitals every 15 minutes for the first hour, if not more, depending on what her bleeding looks like. We're also going to be helping with any routine tests. We're going to prevent excessive bleeding by potentially administering medications if necessary. Um, Maintain uterine tone by administering medications if necessary and by performing those fundal massages. Prevent bladder distension. So, like I said, whenever we want a fundus to be midline, we don't want it to be pushed off one way to the other. If you go and you try to find a mom's uterus and it's pushed all the way off to like her right side, usually it's because the bladder is really full and it's causing that distension. Okay. Bladder distension, we don't want to see either because that can just mean that the bladder is too full or there's something else going on. So we need to make sure that our toileting needs are being met. Okay. Make sure mom is comfortable. She's going to be experiencing a lot of discomfort from the postpartum cramping and just overall her recovery from labor. So we need to provide medication if necessary. She needs to eat. Do not try to get your patient up for the first time after delivery without her having a very good substantial dinner in her belly. Even then, I would give it an hour or two until you try to let her get up and walk. Okay. I've had plenty of moms who, after just giving them regular meals or big meals, still will pass out or vagal in the bathroom because they've lost too much blood or their body's just not ready or they're just not feeling well. Okay. Help with breastfeeding, like we talked about those vaccines in week 2. See if they are wanting those vaccinations before they're discharged from the hospital. Okay. Um, from a psychosocial standpoint, we need to monitor our mom and see how her reaction is to that birthing process. Okay. Some women will have beautiful, wonderful deliveries and births. Others have traumatic births and deliveries. So we need to just gauge how our patient is feeling. Okay. Assess their feelings related to themselves. Are they proud of themselves? How are they feeling? Were they disappointed because they may have wanted a natural delivery and they got an epidural? Were they feeling let down because they wanted a natural vaginal birth and they ended up having to go back for a C-section? We need to assess this part of mom as well, right? The physical part of it is very, very important, but this is right behind that, okay? We are always also trying to prepare our moms for discharge. So helping and talking to them about their self-care and signs of complications, like when is their bleeding too heavy? When are we wanting those different bleedings? Like what is it going to start to look like? We need to tell them like about the rubra, the serosa, and the alba. Okay. If they're taking any medications or we're giving them medications following delivery, we need to talk to them about the regimen, signs and symptoms that to avoid complications that may arise from taking these meds, and then establish like a follow-up schedule when they need to see their provider next, and then give them any community resources as needed. All right. So our transition to parenthood is very, very important, especially for those parents that this is their first baby, right? It is a huge transition. So, attachment and bonding. These are really important things whenever we're talking about postpartum care. This is the process, attachment is the process by which a parent comes to love and accept a child, and a child comes to love and accept a parent. There are two definitions or two terms under here that I want you guys to know. The first being mutuality, which is the infant's behaviors and characteristics elicit a corresponding set of parental behaviors and characteristics. So they're basically kind of understand each other. They have their own little language going on. They know what the other one needs at what time. That kind of interaction. Acquaintance is when parents use eye contact, touching, talking, and exploring to become acquainted with their infant in the immediate postpartum period. So this is just ways that we can assess as nurses, like, are these parents attaching to this infant? Like, are they displaying these signs that are facilitating a good relationship? Bonding occurs through mutually satisfying experiences, and it typically refers to earlier process through which parents become acquainted with the infant. So, um, satisfying experiences, the number one thing, kangaroo care. Okay, if you hear somebody here say that term, It's placing the baby skin to skin with mom or skin to skin with dad. This is a huge bonding experience, okay? Not only for the infant, but for the mom and dad as well, okay? It helps relax both parties, okay? It regulates heart rate, it regulates respiration rate, it helps with baby's oxygen saturation. Placing baby skin to skin and encouraging that type of bonding is extremely beneficial and should be encouraged. Parent-infant contact. So when we're talking about early content, that contact, that's that skin to skin. We're making sure baby's getting breastfed early. If mom wants to breastfeed, it's usually within the first hour of life. A delay in early contact does not necessarily mean the infant will have a bad outcome. Not at all. So for like our C-section moms, right? Typically, after a C-section, that mom isn't seeing or holding that baby until she's back in the recovery room, at least not skin to skin bonding holding baby. Like we still try to bring the baby over to the mom and like put baby on her cheek or put baby on her chest and hold the baby there for her. But it's still not the same as mom being able to physically wrap her hands around and hold her own baby independently. So that does not mean that this baby who was delivered via C-section is going to have delays or any type of abnormality or abnormal side effect. It just means that they're not getting this early contact just quite as early. Okay. Extended contact, when we're talking about this, we're talking about rooming in. So during a mom's hospital visit, we're going to encourage that baby to stay in the room with the mom and the dad for as long as they can, pretty much throughout the entire stay. We're doing all the things that we need to do for the baby at the bedside. We're never taking that baby up to the nursery. We're keeping that baby in the room with the parents. Okay. This slide here goes through communication between the parents and the infants. Obviously, your senses are going to play a huge role in this. So, touch, getting babies skin to skin, eye contact. Mom and dad should be looking into the baby's eyes, should be talking to them. Voice, baby's going to recognize mom and dad's voice because their hearing develops while they're in utero. So, they hear mom and dad talk all the time. So, they're going to be able to recognize and respond to mom and dad's voice. Scent is a big one. So getting baby skin to skin with mom is going to help not only with regulating vital signs, but also with like milk production, right? That's going to stimulate oxytocin in mom, which is going to bring that milk forward from the alveoli to the front of the breast tissue. But it's also, baby's going to smell milk and smell mom and associate that with safety, comfort, food. So mom, she might smell like milk or colostrum, and that might instigate baby to latch and get that first feed. Okay. Entrainment is when newborns move in time with the structure of adult speech. So they're kind of just responding whenever they're hearing specific things the parents are saying, or just whenever they're hearing voices. Biorhythmicity is referring to, so it's like when the fetus is in tune with the mom's natural rhythms. So, putting baby skin to skin whenever baby is crying or upset or aggravated, baby is going to hear mom's heart rate and hear the natural rhythm of the mom's heartbeat, and that's going to soothe the baby. Reciprocity and synchrony. So, reciprocity is a type of body movement or behavior that provides the observer with clues. So, like a baby who's like rooting around or showing like signs that the baby is hungry, that rooting reflex is going to trigger in mom, oh, my baby is hungry, I need to feed her. Okay. That's an example. Sometimes this takes a while to develop with a new baby, especially with like a first time mom who's not used to seeing newborn cues. It can take a while for them to develop that. Synchrony refers to the fit between the infant's cues and the parent's response. So if an infant develops different cries to correspond to different emotions, and then mom begins to understand the difference in these cries. So like you guys might look at somebody or a woman crazy if she says, "Oh, that's the cry that he makes whenever his diaper is dirty." Um, or, "Oh, that means that she's tired. That's just her tired cry." Okay. Like the moms know their babies. They know when a baby is hungry, when they're tired, when they just need a diaper change, or when they just want to be held. Okay. So we need to listen to moms because they definitely know what they're talking about. Okay. So, our postpartum blues, when we talked about the neurological changes that moms are going to undergo after delivery, postpartum depression and postpartum baby blues, that's a really big thing that I want you guys to understand. Um, so, women are emotionally labile and often cry easy for no apparent reason. Okay. Typically, it gets to the worst around the fifth or sixth day postpartum because that's when those hormone fluctuations are starting to level out and starting to decrease and return back to normal. So moms might tell you, like, I just feel so restless. Like, I can't sit still. Um, I'm tired all the time. I can't sleep at night. I have constant headaches. My anxiety is through the roof. My heart feels like it's pounding out of my chest. I'm just sad all the time. I get angry at my husband for like any little thing that he does. All of these things are fall under the umbrella of postpartum blues, okay? And those things are normal, unfortunately. We need to tell our moms, like, listen, like your body just underwent a huge physiological change. Your hormones are going crazy right now, so it is not uncommon to be feeling these things, okay? We just need to be able to tell them when we need to seek emergency treatment or emergency help. Um, when do we contact a provider? If mom is not wanting to take care of herself, or she's not wanting to take care of her baby, or she calls in and she says, I feel like I want to harm myself or I want to harm my baby. Those are all emergencies, and those would not be postpartum blues. That would be like postpartum psychosis or postpartum emergency. Okay. So we need to also educate the partner, right? Because I know if I came home and it was and whenever I come home in the postpartum period and I'm busy breastfeeding and changing diapers, and my husband is too. Well, my husband is going to recognize a major shift in my mood sometimes before I do, right? So it's important for people to educate not only the moms themselves on warning signs and postpartum emotion, but also the partner, because the partner oftentimes is going to be the one to pick up on this first. Okay. Adolescents as parents. We really want to talk about our adolescent population, right? So, mortality rates are slightly higher in infants who are born to adolescent moms, and this is simply because of undereducation or an adolescent not having the resources available to them to make the postpartum period easier. Okay. It can be influenced by mom's inexperience, her lack of knowledge, immaturity. Also, in adolescence, preterm deliveries are higher risk, as well as other pregnancy related complications. So, like we talked about, moms having anemia, adolescent pregnancies having high incidence of anemia. Moms might be more fatigued in the postpartum period because of this, and they may not be as alert, and they may not have support, right? They may not have as much support as they need, okay? They also might be distracted by other external factors like work or school, okay? If they're going right back to high school and they're trying to also be in the postpartum period, that is going to be really, really, really challenging, okay? If they have no choice but to go back to work after 2 weeks, then that is going to be a huge challenge, right? Like, how do we even take care of a baby that, or let that mom, she's kind of like working uphill, like fighting an uphill battle. So, we need to, as her nurse, give her as much resources and assistance as we possibly can. However, like it says here, with appropriate education, a supportive environment, and multiple resources, this vulnerable patient population can be effective parents. Some of the best parents that I've ever met have had their babies when they were 16 or 17 years old. Okay. So just because they're adolescents does not mean that they are incompetent. It just means that we may need to provide them with more resources and some more support. What else can affect transition to parenthood? Infants born to the members of the LGBTQ plus community, and that is because we need to, as nurses, in, encourage the normal attaching patterns, regardless of whether or not a patient or a parent is able to breastfeed. Okay, so if it's a baby born to two men in a homosexual relationship, we still need to be encouraging skin to skin contact. We still need to be encouraging them. Okay, yeah, you may not be producing milk and you may not be breastfeeding, but here's how you can bond with your baby during feeds. maintaining that eye contact, talking to that baby, learning their cues. It really is no difference. We as the nurses and just in general need to be able to provide and change things to format this type of family and this dynamic. Midlife parenting, if it's an older couple, what does that look like for them? What kind of social support do our parents and our couples have? What is the culture that's going to always affect how we're providing our care? Socioeconomic conditions. Are parents eligible for the WIC program? Um, if they are, we need to be giving them these resources. Any type of financial assistance that can be provided to them, we need to also be providing that as well. What is a personal aspiration of the parents? What do they still want to accomplish? Okay. Are they in college? Are they still wanting to finish out a degree? Are they in midlife and they're wanting to go back to school? Like listening to them, talking to them, and helping them achieve and attain these goals is part of our job as nurses. Okay, postpartum complications. Okay, excuse me. This is really important information, and a lot of this is going to be on your guys' exam and on your slides, okay? So definitely pay attention to this part of the PowerPoint presentation. All right. One of the biggest things that we talk about when we talk about postpartum complication is postpartum hemorrhage. Okay, so at the beginning of this PowerPoint, you guys are probably like, what is she even talking about with fundal massages? What is she talking about with uterine atony? Whatever. Postpartum hemorrhage is what happens whenever a mom is bleeding too heavily after the immediate delivery of the placenta or after the delivery of the baby. Okay, so this would be blood loss of greater than 500 mLs following a vaginal delivery or blood loss greater than 1,000 mLs following a C-section, right? Because we gave you those limits at the beginning of the PowerPoint about what blood loss should be, okay? Postpartum hemorrhage can be early, which is up to 24 hours after delivery, or late, and it can happen up to 12 weeks following delivery. I've seen it both. More often than not, if a mom is going to hemorrhage, it's going to be in the immediate postpartum period, right? But I've had it before where moms have come in 4 weeks later because they all of a sudden started having clots and clots and clots pour out, and turns out after a ultrasound, she had retained placenta. Some part of her placenta was still up in her uterus. Okay. What are your causes of postpartum hemorrhage? Over here, we have the four T's: tone, tissue, trauma, and thrombin. That kind of just brings it down to you in a very like condensed, shortened version. So tone, uterine atony, tissue, retained placenta, trauma, lacerations, thrombin, coagulation. We're going to go into these in a little bit more detail. Uterine atony is what happens when the fundus does not remain firm following the delivery of the placenta. Okay, so remember, what is our characteristics of normal? Our placenta should be firm and it should be midline, right? In a uterine atony, a flaccid or a hypotonic fundus may be caused by a big baby, multiple gestation, polyhydramnios, obesity, anything that will enlarge the uterus. Okay, but if a uterus is not remaining firm, we refer to that as boggy. And that is what happens whenever we're pushing on the placenta or not the placenta, we're pushing on the uterus for our fundal exam and we're getting clots and clots and clots because that uterus isn't firming up, right? That uterus isn't contracting. It's not trying to return or involute back to its regular size. So that is a problem. Retained products of conception. So that would be what happens if fragments of the placenta or membranes remain in the uterus following delivery of the placenta. Okay, so think about it. If you have your uterus, right, and it's trying to clamp down postpartum to reduce the amount of blood and it's trying to shrink back to its normal size. But we have something that's stuck in there. Is it going to go anywhere? Is it going to be able to shrink? Is it going to be able to return? No, it's not. It's not going to be able to fully contract because there's something up there in the way. Typically, it's part of the placenta that breaks off when the placenta is trying to detach from the endometrial lining after the delivery of the baby. But also, like some tissue can be stuck up there, trailing membranes from the amniotic fluid, whatever it may be. Typically, if this is the case, Providers will do what's called a manual extraction, which you have a picture up here in the right-hand corner of your screen, where they don sterile gloves and they physically reach up into the uterus and try to scoop out anything that's remaining. It sounds about as comfortable as it probably is. Typically, this is something that providers are doing as not necessarily a first resort. They're going to try and give medications, different meds to try and get the uterus to come back to its normal size and to expel anything else that might be up there. But a manual extraction can happen. If there is a manual extraction, when the provider puts their hand up in the uterus and does a manual sweep, this patient needs antibiotics afterwards, right? Because they just were exposed to a lot of infection or potential infection causing agents whenever that provider went up to do that exam. Okay. Um, Placental complications we refer to these as like placenta accreta, an increta, or a percreta. Okay. So when we talk about these three things, an accreta, an increta, and a percreta, these things occur whenever the placenta is abnormally implanted, adhered, or is what we would call invasive. Okay. I have a picture on the next slide. Let me pull that up really quick. Okay. Here, not the one on the right, those are hematomas. We're going to talk about those in a second. Over here on the left, here's your picture of your normal uterus, right? On the left hand, on the first picture on that left hand side. It is just in the uterine or the endometrial lining. You see how it doesn't go into the muscular or any other level below. Your accreta, you see how that placenta is starting to kind of grow into that lining, into that wall, into that uterine wall a little bit more? And then your increta, that's growing down into like your musculature. Your pericreta is all the way down into your musculature. These three, an accreta, increta, and percreta, those are really, really big bleeding risks because your placenta has basically grown through the area that it's supposed to be in. So whenever it tries to detach, it's not going to fully detach. You're going to have a lot of injury here where that placenta has embedded. So back to this slide here. So, your accreta, like I said, it's that slight penetration of the myometrium. So it goes past the endometrium into your myometrium. Your placenta increta is the deep penetration of the myometrium. And then your percreta is a perforation of the myometrium and the uterine serosa. And it's probably going to involve adjacent organs. Okay, so that percreta is extremely dangerous, and oftentimes patients need to get a hysterectomy. Okay, risk factors for this would be if they had prior uterine surgery that had some scar tissue, endometrial defects, any type of fibroids. Sometimes, if moms have to do IVF or use any type of assisted reproductive technology, it can result in them developing an accreta, or they're at a higher risk for developing accreta. Multiparity, so like if they're pregnant with twins, that can cause that. And then a maternal age greater than 35. Okay, so those are some things that can cause an accreta or a percreta. Okay. Lacerations of the genital tract, obviously, those are going to cause us to hemorrhage. If we have any type of cut or any type of wound, that's going to increase our risk for bleeding and is something that needs to be managed efficiently and very quickly in order to prevent excessive amounts of blood loss. Okay. Your providers are responsible for assessing the perineum in the postpartum period and for determining what stage the laceration is and how to repair it. Okay. Hematomas. I just had that beautiful picture up here on the right. Those are some hematomas. Um, Hematomas are a collection of blood in the connective tissue. Okay. They can be vulvular, vaginal, or retroperitoneal. The most common type and the ones that I have seen the most of are vulvular. And typically these are seen with forceps-assisted delivery births, episiotomies, or in a first-time mom who has never had given birth before. Um, the most common symptom of a hematoma is pain or intense rectal pressure, and then these may have to be surgically evacuated. So we may need to use surgery to kind of reduce the hematoma. Okay. They're extremely painful. Moms are typically extremely uncomfortable whenever they have a hematoma, and you'll be able to see it, especially if it's vulvular and it's right at the opening. Okay. A uterine inversion. this is a bad time. This is what happens whenever the fundus collapses into the uterine cavity. So your uterus basically turns inside out. It's very rare, but it's life-threatening. Okay. So how do we know that a mom has had or experienced a uterine inversion? She's going to hemorrhage, right? She's going to bleed pretty, really bad and very quickly. She's going to go into shock and she's going to complain of excruciating pain. Okay. Typically, after delivery, mom's pain level is way less than it was when they were laboring. Okay. So if all of a sudden they're like writhing in bed, screaming in pain, there's something else that's going on. The most common cause of a uterine inversion is whenever there's excessive umbilical cord traction with a fundally attached placenta, and then fundal pressure when the uterus is atonic. Okay, so if a provider is trying to pull a placenta that's not ready to be delivered yet, and they pull too hard on that umbilical cord and that placenta is pulled, it's going to start pulling that uterus and that uterine wall with it. Okay, and that can cause a uterine inversion, or pushing on the placenta whenever that uterus does not have good tone, and you're not providing that support at the base of the uterus, to provide fundal support as you're massaging. Okay, a uterine inversion is a OB emergency. We need to take her back to the OR pretty much immediately. Okay. Um, we're gonna make sure mom is not having anything to drink because we're gonna be taking her back for an operation. And then basically, the provider has to go in and replace the uterus back into the pelvic cavity. Okay. So this is a really big emergency and we have to deal with it quickly. Subinvolution of the uterus is delayed return of the enlarged uterus to a non-pregnant size and function. Okay. Um, so like we already talked about this at the beginning of the PowerPoint. So signs and symptoms of this could be prolonged lochia discharge, irregular excessive bleeding, and a hemorrhage. Okay. Coagulopathies. So like bleeding disorders that may be increasing mom's bleeding. So if mom has a history of a bleeding disorder, she's going to be extra coagulable and might be having a hemorrhage. Or if we hear a mom that says, like, yeah, with my last baby, I bled a lot and they had to give me a lot of medications. If a mom has a history of a postpartum hemorrhage, she has a much higher chance of having a postpartum hemorrhage with subsequent pregnancies and deliveries. And that's something we have to take into consideration whenever we're preparing her room for birth. All right, as far as a nursing assessment, like I just said, we need to identify our patients who are going to be at risk for a postpartum hemorrhage. So, moms that are having or delivering a big baby. Um, if mom has a history of a postpartum hemorrhage, if she does have clotting disorder or bleeding disorders, if she's been losing blood a lot during delivery, most of the time she's going to lose during labor, she's going to lose blood during delivery. Okay. We need to be able to tell how much blood loss. So that is a QBL, quantitative blood loss. Your job as the postpartum nurse is to weigh pads and weigh under things under mom so that we have that number for providers. Okay. We're performing that firm fundal massage where we're putting one hand at the top of the uterus and rubbing very firmly while the other hand is supporting the uterus at the base, so that the uterus, we do not have an inversion, right? If we're pushing too hard on the top and we take this hand away, we run the risk of just completely pushing that uterus, okay? Especially in moms that have had multiple babies already. Their musculature is not going to be as strong. We're assessing moms frequently in the recovery period. Typically, it's every 15 minutes for the first hour to 2 hours for a C-section delivery. We're assessing their vitals at a 24 to 48-hour basis, depending on if they've received Duromorph via their spinal or not. So just adhere to your hospital policy whenever referring to that. Um, if we notice that mom is having excessive amounts of bleeding, we need to be able to identify whether that is fundal or if it's perineal, right? So if your fundus is really, really nice and firm and there's minimal amounts of clots, but you're still having gushes of blood, typically that means that mom has a laceration that hasn't been fixed or a laceration that's reopened after a provider has already sutured. Okay. So we need to be able to update our provider on this. And if your blood loss is still pretty heavy, but your fundus is remaining firm, typically it's because of a laceration. and then we're treating our moms accordingly. Okay. So during our nursing assessment, what should we see? What is concerning versus what is not? Um, these things are really important, and all of these things we're going to be talking about during class. Nursing interventions. We need to identify our priority. What should the nurse do and why? FFP, our fundus folate and our Pitocin. We're massaging the fundus. We need to manage our bladder because if our bladder is full, it's pushing up on that uterus and it's not allowing that uterus to fully contract. So a full bladder means more bleeding. So we need to straight cath a patient or help them to the bathroom if it is appropriate. Okay. Medications are uterotonics. You guys will need to know this for sure. So, Pitocin, that is going to help with our uterine contractions. We're going to be giving that in the immediate postpartum period, right? After every delivery. Methergin is a medication that we will give if moms are bleeding a little bit in excess. When can we not give Methergin? You guys definitely need to know this. We cannot give a mom Methergin if she has high elevated blood pressure. Hemabate is another medication that we will give. It is a uterotonic. It's going to help clamp that uterus and prevent any excess bleeding. We cannot give a patient who has a history of asthma Hemabate. Okay, so you guys need to be able to keep those separate and know when we can and cannot give those meds. Cytotec is probably the second most common postpartum uterotonic that we're going to administer following Pitocin because it has the least amount of side effects and it's typically pretty safe with any patient postpartum. Cytotec is typically given 1,000 milligrams rectally after delivery. A provider will give that in the immediate postpartum period. Um, it is also something that can be given sublingually. Okay, I want you guys to go through these four meds and know them pretty well. We need to make sure these patients have large bore IVs. We're monitoring vitals and administering oxygen if necessary. Giving IV fluid and blood products because we need to make sure mom is still perfusing during that postpartum hemorrhage period. We also, if we get to the point of emergency, we're going to consider a Bakri balloon or a Jada device. I'll talk about that at the next slide. How can we assess and know that our interventions worked? Obviously, our fundus is going to be firm. We're going to have a decrease in our bleeding, and then mom's vital signs are going to regulate. Okay. So these two devices here are a Bakri balloon and a Jada device. So both of these are going to be put up into the uterus to help maintain uterine tone. Okay. So for the Bakri balloon, this isn't used as frequently anymore. I've used it about probably 3 times in my career. Now we're going more towards the Jada device. So the Bakri balloon, you insert a catheter up and then you're instilling water into this balloon, and that balloon keeps pressure on the uterus to keep that uterus contracted and to keep blood from forming, okay, from being produced. Bakris typically last, like they usually leave those in for 12 to 24 hours, whereas a Jada stays in for a little bit less time typically. And a Jada device, this device gets still put up into the uterus and it's hooked up to the wall suction, and it basically keeps that uterus contracted that way. Okay. So when we're talking about treatment for postpartum hemorrhage, we can use this mnemonic. What is our motive? So what medications can we use? We can use oxytocin, Methergin, Hemabate, or Cytotec. And also, we need to call our doctor. If your patient is bleeding to the point that you're using medication, you better believe that your provider should be at the bedside. Oxygen should be administered because we want to keep mom's tissue perfusing, and we want to make sure that she's hemodynamically stable. Tone. As we're assessing our fundus, we're assessing our uterine tone. So if our fundus is not firm, then we need to be massaging the fundus to firm it up and also identifying what the sources of our bleeding is. We need to have an IV, preferably an 18 gauge or greater because we're most likely going to be giving this patient blood, monitoring our vitals and emptying our bladder. Okay. Venous thromboembolic disorders. So these are the DVTs and the SVTs. You guys have seen this in the other classes. I'm not going to spend a lot of time talking about this, okay? Just make sure you know the signs and symptoms very well. Postpartum infection is not super common, but it can happen, so we are going to discuss it. So, endometritis is something that is infection of the lining of the uterus that usually begins at the placental site but can expand to the entire endometrium. Okay. Signs and symptoms of this would be a fever, increased pulse, chills, anorexia, nausea, fatigue, lethargy, pelvic pain, uterine tenderness, and then foul smelling lochia. Typically, if a patient presents with any of these things, we have to administer broad spectrum antibiotics, encourage hydration, and encourage moms to rest. A wound infection or an incision. So, this could be like a postpartum C section surgical site, but it could also be like if a mom had an episiotomy or any type of laceration or perineal laceration. Moms could develop a fever. We see some redness, some swelling, warmth, tenderness, pain. Like I said, they may experience that like wound drainage, some wound separation, um, and just overall not feeling very well. Anything like that, um, most likely they're going to provide broad spectrum antibiotics for treatment. Um, Other things that we could see are sometimes urinary tract infections because of the location of the um, incision or whatever it may be. And then the last one we're going to talk about is mastitis. That is inflammation of the mammary gland in the breast. That's what happens when one of the breasts gets really large, red, swollen. There's weird discharge that's coming from the nipple. Moms are having a hard time with breastfeeding because it's extremely painful. For this, we want them moms to continue to nurse on that side, and they're not going to love you whenever you tell them that, but that is going to help with reducing that swelling. We're also going to give them antibiotics and encourage them to use warm compresses. Okay, this slide I do want you guys to review also. The differences between baby blues and postpartum depression. Okay, it's very important to know the differences between these two things. So, with baby blues, moms are pulling away from people. They want to be alone. They're trying to isolate. They're feeling angry and moody. They have that emotional roller coaster going on where they're just mad or sad or just very dramatic feelings all the time. Feeling hopeless or overwhelmed. They're having difficulty sleeping or sleeping too much. Whereas with postpartum depression, there are baby blues that aren't going to go away after 2 weeks. There's thoughts of harming themselves or their baby. They're having difficulty with thinking, concentrating, or making decisions. They're having trouble taking care of their baby or struggling to do everyday tasks. Okay. So those are the biggest differences, but I would definitely know the differences in how we would educate our patient on what is a normal postpartum experience and what is something that you need to seek further care. Okay, so that covers our recording for this week. So we just talked about chapters, I believe, 18 through 21 in our textbook. And that covered the postpartum nursing care and assessment. So if you guys have any questions or want any other points that we talked about in this PowerPoint clarified, please don't hesitate to reach out. My contact information is within your shells in Canvas. Okay, have a great night.